Hello and welcome back to my YouTube channel. In this short video, I'm going to teach you what I think are the essentials in understanding what it means to be in a state of estrogen dominance. Why is this important? It's because so many women in the reproductive and perimenopausal years are suffering from symptoms of estrogen dominance, and in many cases, conventional medicine is ill-prepared to help people with this. These symptoms are diverse. I've had patients in my practice with everything from weight gain, bloating, breast tenderness, mood and memory changes, migraine headaches, skin, hair, and nail changes. The clinical effects are diverse. My name's Scott Resnick, and I'm a medical doctor who believes that you are the best steward of your health care, and I'm making these videos to give you all the tools, all the tricks, everything that I learned in a decade of practicing functional medicine and more than 20 of using bioidentical hormones in my patient population. In this video, we're going to go over three things. The first is an understanding of what the menstrual cycle is for. I know that might sound pretty basic. In the next, what I'm going to do is graphically demonstrate to you how a woman typically gets into a state of estrogen dominance. And in the third part of the video, I will review with you what some of the behavioral and environmental factors are that are in your control to actually begin to lower that state of estrogen dominance. So the first thing, what is a menstrual cycle? Of course, everybody knows it produces an egg so that humans are able to reproduce. A typical menstrual cycle is 28 days long with about 3 to 5 days of normal menstrual bleeding. Now, the American College of OBGYN states that a menstrual cycle is normal if it's between 24 and 32 days in length, provided it is associated with what is known as meliminal signs, and I'll go over those with you in just a moment. A meliminal sign is a clinical sign that tells a woman that she ovulated well and that she's making progesterone in the second half of her cycle. In my practice, I would ask my patients, if you were on a desert island and you had no calendar, no cell phone, would you know that you were about to ovulate or that you were about to get your period? And if a woman said, yeah, doc, I get bloated, my bowel patterns change, I retain water, my breasts are tender, I have mood and memory changes, my thinking isn't as clear, these are meliminal signs, and they are associated with the rise of progesterone in the second half of the cycle. What's important to remember here is that a menstrual cycle is a very energetically demanding process, as is pregnancy. And humans were equipped with an ability to either keep that process going on because times were good, we had plenty of food, or were able to dial back the energy that is required in an ovulatory process when we were, say, migrating or when our tribe was starving. It makes sense. If you are traveling across the desert, you didn't collect enough food, that's probably not a good time to get pregnant and probably not a good time to have a menstrual cycle in which you're going to lose between 60 to 80 cc's of blood and the associated heat and iron that goes along with that. What's interesting is that as I mentioned, it's a very metabolically active process. So for a woman to ovulate well, she needs to have, one, a sound nutritional standpoint. Number two, she has to have balanced energetics in her body. And this is the constellation between cortisol, insulin, and thyroid. And those of you who are following this idea of estrogen dominance know that stress and cortisol weighs heavily on this, as does thyroid function. And of course, there's also insulin function, because one of the most common causes of abnormal menstrual cycling or dysfunctional uterine bleeding is a condition called as polycystic ovarian syndrome, or PCOS, which is directly tied to weight and obesity generally. What I want to do next is explain what happens over the course of the month, and to do so, I'm going to graph this out on my iPad, and in just a moment, you will see very clearly what it means to be estrogen dominant. So what I've done is I've created a little graph here that shows hormone levels graphed against the menstrual days. And in this example, we're going to say that this woman's having a 28-day cycle, which, again, the second half of the cycle is tightly conserved, meaning she ovulates on day 14. While we're on this topic, if you are having cycles every 24 days with meliminal signs, your day of ovulation is probably day 10, because the luteal half of the cycle is tightly conserved. So take 24 days, subtract 14, you get 10. Conversely, a woman who's having cycles about every 32 days would be expected to ovulate on day 18. In a typical cycle, there are 2 peaks of estrogen, and I'm going to draw these out in a dotted line. So you can see that estrogen rises in the first half of the cycle and in the second half of the cycle as well. Now, in a normal ovulatory cycle, progesterone is almost immeasurable in the first half of the cycle. So you can see it's very, very low here, and then it rises up in the second half of the cycle. The dropping off of progesterone at the latter half of the luteal phase is what actually triggers the menstrual cycle. But the important thing right here is you can see that there is an estrogen to progesterone relationship, which is small. But what happens is that when a woman becomes nutritionally deficient, when her thyroid, insulin, cortisol aren't working, when her gut's not working, when she's infected, when she's stressed, when she's inflamed, oftentimes she cannot ovulate as well or as efficiently. And what happens is that the progesterone in the latter half of the cycle doesn't go up as high. And this has been followed and known in the reproductive endocrinology literature for probably 4 decades now. So now in this case, we see that the progesterone is low, as it should be in the first half of the cycle, but doesn't rise up as much in the second half of the cycle. Now, what you can begin to see is that this estrogen to progesterone ratio is larger. This woman is becoming more estrogen dominant relative to her progesterone. And as women get more towards the ends of their reproductive ages, I mean, early 40s into the real perimenopausal years, around age 50, we see that progesterone rise is even less still. And we get an even greater estrogen to progesterone imbalance, thus estrogen dominance. Now, I said that in this video, I'd also go over some of the more common causes of estrogen dominance in our society. And I can tell you that probably the number one revolves around weight gain, accumulation of extra fat cells, because these fat cells are like little estrogen factories. They have higher levels of aromatase. Aromatase converts testosterone into estrogen. The other thing that I want you to consider is the presence of some of these xenobiotics, some of these xenoestrogens. These are endocrine activating molecules in our environment that seem to act like an estrogen on estrogen sensitive tissues. I mean, like the uterus and the breast. But the values aren't going to be found in a typical hormone blood, saliva, or urine study. Hopefully this is helpful. You can see from this graph that estrogen dominance is most commonly a function of an estrogen to progesterone imbalance in the latter half of the cycle. I can't tell you how many women in my clinical practice have benefited enormously by supplementing progesterone, typically in the second half of the cycle, to try to mimic what would be a more normal cycle. In rare cases, I have seen women who've benefited with progesterone in the first half of the cycle as well. But remember, this needs to be stair-stepped. In other words, the progesterone used in the first half of the cycle should be lower, with a higher amount in the latter half of the cycle to more closely mimic a normal ovulatory cycle. As always, I'm making these videos for you. I want to see you become best stewards of your own healthcare, and I want to see this whole juggernaut of mainstream medicine turned around as we, the individuals, become more empowered in our ability to take care of ourselves and make good medical decisions and actually have the resources to get something done, because God knows in so many cases, our doctors aren't taking care of people. Of course, this is YouTube. I'm almost obliged to say comment, like, and subscribe. If you comment, I'll be sure to respond to your comments personally. Hopefully this was helpful. Now, there's a whole additional discussion I could have about estrogen dominance in the postmenopausal woman, but typically this is going to be the result of hormone replacement therapy that's not being administered correctly or not being measured and managed correctly. But I'll leave that for another video. Either way, be well. I will see you in an upcoming video.